All right, everyone. Hello and welcome back to the First Sis podcast. I'm your host, Taylor Goodstein. Our guest today, I'm very pleased to welcome Dr. Tullika Garg, who is a urologic oncologist over at Geisinger Medical Center in Danville, Pennsylvania. She got her medical degree from Baylor, went on to Medical College of Wisconsin for residency, and then did her fellowship training at Memorial Sloan Kettering in New York City. So welcome, Dr. Garg.
Thank you. I'm glad to be here.
And what we're going to be talking about today is geriatric oncology and how that applies to urology. So I know this is something you're pretty passionate about. Our learners may have actually seen that you've written the AUA, core curriculum on this topic.
Yeah. I guess I've always kind of been interested in older people. I never really got to know my grandparents because they lived so far away. They lived in India, and so I think I was always kind of fascinated by that grandparent relationship. Early on in medical school, I thought I was going to become a geriatrician, actually, and then I got really interested in urology, and I realized that I would be taking care of a lot of older adults as a urologist because as urologists, we all treat a lot of diseases of aging, and cancer is definitely one of them. And then when I got out in practice after fellowship, I was just seeing a lot of older adults with urologic cancers, and I was realizing that the decision making was very challenging. We're very much in a data-free zone when it comes to older adults, and a lot of our trials are done in younger people, and so our older adults react differently to surgery and to medications. And I was having a lot of really interesting conversations with my patients and hearing their stories, and it just reignited my interest in geriatrics. And so I started going down that line of investigation and getting to know a lot of geriatricians and pursuing this area.
You hit on something about clinical trials being kind of exclusionary to the geriatric population. Could you hit on that a little bit more, like exactly what you mean by that, and what percentage of cancer we see in older adults versus how they're represented in the trials typically?
Yeah, so about 60% of new diagnoses are in older adults, and just to clarify, we should kind of define what we mean by older adults. And typically in the United States, we use the Medicare eligibility age, so age 65 and older. Although people are heterogeneous, and so younger people can seem to have aged more and older people can seem more fit. So, anyways, that's we should definitely think about how we're defining older adults. So about 60% of new diagnoses are in people who are over 65, and clinical trials historically have enrolled much younger populations. I believe it's about 10% of clinical trial enrollment is older adults. And a lot of that is related to how we think about exclusion criteria for clinical trials. We think about the ECOG performance status, and most trials enroll people who are 0 to 1. But a lot of older adults with cancer have more poor ECOG performance status, so they may be eliminated from a trial from the outset. And then there are other coexisting chronic conditions, such as renal dysfunction. We can prevent them from becoming eligible for a clinical trial.
So when you see one of these older adults in your clinic and you're considering sending them to medical oncology to talk about, one of these drugs, one of the new kind of immunotherapies, for example, I'm really curious on this podcast to kind of provide people with examples of how you actually speak to patients in the clinical setting. So considering that a lot of the trials haven't included a lot of great data for older patients, how do you use that? How do you communicate that to them in clinic? Do you communicate that?
Yeah, I do. I'm very honest with them about the fact that, we don't have a lot of data on side effects in our older adults with a lot of these drugs, and both new and old. And I do use geriatric assessment in my clinic. I use a completely survey-based geriatric assessment tool called the Cancer and Aging Resilience Evaluation, which was developed by Dr. Grant Williams at University of Alabama. So I use that to kind of understand where my patient is at physiologically, um, because I don't like to just go by chronologic age alone. Because as I said earlier, our patients are heterogeneous. So based on kind of what I see with their physiologic age, then I, talk with them a little bit about what they could possibly expect if they were going to go on a chemotherapy or an immunotherapy. There are some great tools out there too. There's the Cancer and Aging Research Group's chemotoxicity calculator. I use that one a lot in my clinic. It helps to predict the risk of grade 3 to 5 adverse events in older adults. It's very simple and easy to use. It's online. Um, and then yeah, we engage in a shared decision making process. I think shared decision making is a really important part of how we communicate with our older adults. I like the three talk model of shared decision making, which is team talk, option talk, and decision talk. So team talk is you're just setting the stage, understanding somebody's goals and preferences, letting them know that they're all part of the team. And, a lot of that is also including in the informal care partners, whether that's their spouse or adult child or neighbor, whoever they trust to help them make medical decisions. They're a really integral part of the team. We also in the option talk, we talk about the risks and the benefits of each of the different options that are on the table. And then in decision talk, we're trying to come to a decision that aligns with that person's goals and preferences. And then that kind of helps to decide what we're going to do. I also really try to refer my patients to medical oncology so they can have a conversation with the people who are going to be giving them the drugs. Because as a surgeon, I can talk to them all day about chemo, but not really, know what they're really going to feel when they're on it. So I do always give them the option to go and talk with the medical oncologist and then circle back and talk with me some more about what they want to do.
I like the that three model, that the talk, option, and decision, that you use that as a framework, I imagine, for a lot of your visits with patients. You did also mention that score, the Garg score. I just wanted to let people know that's available on MD Calc, and like you said, it does look very easy to and intuitive for urologists. There was another one I saw, the crash score, which seems a lot more complicated. I'd imagine you save that one for medical oncologists to use.
I do, and I feel like it's great for patients with more hematologic malignancies. The one thing I really like about the Garg score is that it also includes GU malignancies. That is like one of the point values in the score. So I feel like it's a bit better validated for our urologic patients. Although, I will say, it was all developed during the age of chemotherapy only. So, when we're thinking about like bladder cancer, like the Niagara trial, and patients are now getting immunotherapy plus chemo, it doesn't really assess for the immunotherapy part of things. And I'm really hopeful that maybe someday we'll have a calculator for immunotherapy as well.
Yeah, that's validated in our, our new age. It's one of the problems with progress is as soon as you move forward, all the tools that you used before become not helpful anymore.
Yeah.
Yeah. So you talked about the survey that you use specifically for patients and the Garg score. Is there anything else that you use to assess these patients? One of the things I'm thinking of is a get up and go, sort of physical test. And of course, obviously, we have to balance your busy clinic with trying to do the right thing to assess these patients.
Absolutely. So there are like a million different tools out there for like frailty screening, for geriatric assessment. Um, and at the end of the day, I think it's important to just to try something, use something. Um, because it's we're not geriatricians, and we're just trying to identify the patient who is vulnerable, who may benefit from support. And so using any kind of a frailty screening tool, I think is great. And will give you more information. So other tools that I've used, there's a 5-item screener called the Frail Scale. It's actually really great for like working with your anesthesiologists, because it has really been validated in anesthesia clinics, like preoperative optimization clinics. I also really like the Geriatric 8, which is actually recommended by the International Society of Geriatric Oncology for prostate cancer. Also, very simple 8 items, very straightforward to use. Time Never Go is great. I mean, it's so well validated. But it can be tricky because it requires some extra manpower, or you have to kind of find somebody to walk the patient safely for a time up and go and have space in your clinic to have them walk. So that can be tricky. But, just even if you're not using a validated screener, just observe your patient, have them get up on the exam table and see, are they using both of their arms to try to stand up? Do they have an assistive device? Watch them walk up the hallway. How is their gait speed? You can kind of just, those are quick, easy ways to kind of get a sense for what's going on with your patient. I also really love the question, tell me what a typical day is like for you. Um, and that can also be very telling about how active they are. Like if they're telling you, well, I went to Silver Sneakers, I was out grocery shopping, I cooked dinner, that's a robust patient. If they're telling you, well, I spend most of the day in the recliner and just getting up to go to the bathroom or to get, a bite from the kitchen, then that tells you something else about, other activity levels.
That's great. I feel like I've tried a lot of different versions of that, like, how often are you out of bed or how much time are you sitting in the chair, but just what's your day like is such a great just way to get that gestalt. I'm definitely gonna steal that. Um And would you say, like, if you're not using these validate, like if you don't have time or you're, against using these validated questionnaires, what would you say, like, if, as a surgeon, what would you think is the kind of easiest, quickest way to just look at somebody and like red flags go off for taking that person to the operating room, in your opinion?
Probably asking them about falls. I mean, every patient has to be asked about falls in the last 6 months. It's like a hospital policy or federal policy now. The nurses are asking that. Just take a look at what the answer is. I mean, if they are falling a lot in the last 6 months, that's probably not somebody you want to take to the operating room because it signifies increasing frailty. And they're going to be at a higher risk after surgery.
I will admit I don't think I've ever looked at what the answer is to that falls question, but I will now. No, if you do identify a patient who's frail at Geisinger, what resources do you have available, or do you try to send them to like improve their fitness? One of the things I'm thinking about are geriatric oncology programs. We had that at my residency at Ohio State, like a very specific group of geriatricians that work with cancer patients. And I wanted to know if you had something similar to that, or you use something else.
Oh, we don't. And I think that's the norm. I think for most places, Ohio State's program is incredible, and not everybody has that, even at major academic centers. And actually, geriatric oncologists, medical oncologists are such a shortage specialty, like us in urology. But I think there are some different things that you can do to try to optimize your patient for surgery. The American College of Surgeons they have a guideline that they wrote with the American Geriatric Society. It's kind of dated now. I think it came out in 2016. That is all about the preoperative evaluation and also offers advice on different targeted things you can do. But I think just at a baseline, um, working with the patient's primary care doctor, to, try to figure out if there's anything that's inappropriately prescribed, and, something that's on, there's this thing called the Beers criteria. If you have a patient who has medications that are on the Beers criteria, it's inappropriate prescribing for older adults. Try to work with the primary care to get them off of those medications. Um, Physical therapy, I think, can be very helpful for patients. There's a lot of talk around rehab or prehab, rehabilitation, which the studies have been pretty mixed actually about the benefits of rehabilitation. And, I think it's tough to get somebody to exercise who has never exercised a day in their life.
Yeah, I
Um,
worry that it's the time, it's like what right as like it's not prehab shouldn't be started a month before surgery. It should be started 10 years before surgery.
I feel like we should all be pre-happy with
Yeah.
the lives, but
At all times.
yeah. But I think there are, some benefits to patients to at least, like, I tell them just go for a walk. Like, go walk to your mailbox and back, like a couple times a day and see, if just even that can help them to get a little stronger in the weeks, leading up to surgery. Um, I actually have been using a brochure from Fight Bladder Cancer UK. They have a chair exercises brochure. So I've been giving that to patients. Or I've been referring to them to physical therapy, to just do some strengthening, simple strengthening things at home. Um, and then, nutrition, I think, is really important to try to talk with them about increasing their protein intake, using different nutritional shakes, and referral to a nutritionist, I think, can be really helpful. Um,
Do you have a preferred shake, or you're just like any shake with protein in it?
but anything that they're willing to drink that has protein in it.
Okay.
I mean, I think just getting it into them.
Because I've told patients, I'm a proud member of Costco. And there's those big, like you can get really big jugs of protein at Costco. And I think that's probably financially, better for patients than insurers. So I've told people, I'm like, just go get one of those, and drink one of those every day. So that is fine. I know, speaking of different types of nutrition, there was recently a study, the SWOG 1600 study that was published. Can we talk a little bit about that and the results of that? Because it was ultimately a negative study.
Yeah, it was. So they were looking at immunonutrition in patients undergoing radical cystectomy, and then they looked at 30 and 90-day outcomes, and unfortunately, complications. And unfortunately, there was no difference between the group that received immunonutrition and the group that didn't. And I believe there was there was also a trend. towards improved survival, but it wasn't
Yeah.
significant. I don't really know what to think of that study because it seems intuitively that improving nutrition should improve outcomes. But one thing that I would say about some of these trials also that involve older adults, I don't think that was specifically geared towards older adults, but it's important to think about what outcomes matter to the older adults too, because I think about, you know, 30-day outcomes and 90-day outcomes are really important to hospitals, and are very standard outcomes that we are are easily measured in studies. And we all use those outcomes. But I think there's also increasing interest in looking at additional outcomes that are specific to older adults, like, time away from home,
Mobility.
mobility. There's also like this really interesting mobility measure called life space mobility, which is, how confined are they to their house, or are they able to, go out and about? We should look
Interesting.
more for like social interaction and, just overall well-being. Um, so, I think in addition to measuring some of, the traditional outcomes, I think I would be curious to know if there was a difference in some of the, age-specific outcomes that weren't measured.
In that study. Yeah,
Yeah.
I think one of my big takeaways from that study, and I don't know exactly what the control oral supplement was, but it wasn't like, nutrition versus nothing. It was this specific immune nutrition versus an oral supplement. So that tells me it's like, okay, so just supplements do well, whichever one, or like we didn't have a control group of patients that weren't on anything, but that kind of drives the point home for me that, like, whatever it is, it doesn't necessarily matter what it's made out of. But if you had to choose like one thing for a patient, like they're really overwhelmed coming into surgery and you're like, what can I do before surgery, but I'm nervous and pressed for time, between exercise and nutrition, what would you have someone focus on?
I would probably say the nutrition piece, um, because I think the exercise piece is hard, um, i- for older adults, especially if they have poor mobility at baseline. So if they can take up, I mean, I always tell them it's like training for an athletic event, like getting ready for surgery or for chemo. They whatever like athletes do, they need to do as well.
Barbell load.
Yeah, exactly. They need to get themselves ready because their body is going to be put through a physical test.
And then the chair exercises pamphlet. What's an example of one of those exercises? I'm just curious.
Oh,
Do they like lift? It's like lifting their legs like straight up or something like
yeah,
that.
like standing.
Okay, got it. Got it. Okay, so you got it.
Yeah. Yeah. So simple things, that anybody can do, with modification.
I really loved you talking about the difference in outcomes that older people care about that's different from what we measure in cancer. Obviously, we're very focused on hospital readmissions and the big bad medical complications, and then obviously oncologic outcomes. But we don't do a lot to think about mobility and family time and things that actually matter to patients. So how do you have that conversation with patients when preparing for large surgery?
Yeah, I often will ask them what they're looking forward to. Um, a lot of times I hear in my clinic, um, I have a grandkid who's graduating from high school, or, my like grandson's getting married, or, you know, my daughter has a big milestone at work, or, they have, a lot of times it's celebrations that are coming up. Um, but I hear about my patients, but I do ask them, what matters most to you? What are you afraid that could happen from the surgery that might prevent you from doing something you enjoy. Or, I like to ask them what they enjoy doing.
That's
um,
great.
yeah.
So I've got two things now. I've got what's your typical day look like and what are you looking forward to? So I have tools in my toolbox. A little bit of a tricky conversation. I've struggled with this personally with a patient who is very unfit for anything, and we're talking about, you can't surgery, thinking of let's say it's a bladder cancer patient, surgery is not an option, bad kidney function, so chemo's not an option, like you can't get a full resection. I'm thinking specifically of a patient I recently saw. It's such a large amount of tumor, you can't do a radical TUR, and it's this woman was in her 80s, and I'm trying to very delicately say, like doing nothing is okay. And that conversation, from my perspective, I remember before my grandma passed away, she was in her 80s. And like, if somebody had come to me and said, "Oh, we're going to give your grandma chemo," I would have been like, leave that woman alone. Like, nobody is doing that. But some people have gotten really offended and really upset with me for suggesting not to do anything. And I think some of that maybe comes from the way that we view cancer as like this fight. So I was wondering if you had any experience with that and kind of broaching that subject delicately.
It's interesting. I think a lot of my patients who are unfit know they're unfit, actually, like deep inside. And they're kind of relieved when you're honest with them about it. I think sometimes it's also like kind of onboard some of the informal care partner who may not be really ready or willing to hear that news. But it's I just try to be really upfront and honest about it. And I tell them that, because a lot of them say, "Oh, it's okay if I die on the table," or it's
You're like,
okay.
not for me, actually.
I, I would be pretty traumatized
I
to
would.
die on the table. That's not an outcome I would want. But I also talk to them about, the outcomes that they may not think about. Like, if I did this operation and yes, you survived it, you got out of the hospital, but you may end up in a nursing home for the rest of your life. Or you may have to, go to rehab after your hospitalization to recover. And a lot of people just don't want to go to rehab. Um, or, I tell them, well, you enjoy working in your garden right now. If I did the surgery, I don't know if you're going to be able to bounce back to being able to work in your garden next summer. So, I think sometimes trying to align your recommendations in a way that is relevant to the individual. And if you've done the work up front of trying to understand what's important to them, it's easier to circle back to those options. Um, and literally, I always list out all of the options, and doing nothing is always, I always tell them doing nothing is always an option, just so that they know it's not like, you know, I'm not coming out of left field with it. I give them the whole spectrum, and then I tell them the risks and the benefits of each.
Yeah. Yeah, being honest, and I agree. I think if you do that, you buy yourself that goodwill ahead of time by knowing what's important to them. It can make it easier to have the harder conversation.
Other thing I was going to say is that sometimes people have to go and have those conversations with, get a second opinion, or they need to go and talk to medical oncology. And I always tell them, nothing is ever a binding agreement aside from surgery. What
Yeah.
I really do to take that back. But, for some of the other treatments, I always tell them, well, you can go and hear about it. And if you can try it out, and if it's not working for you, you don't have to keep going. And
That's a good
sometimes it
point.
gives people the freedom to say, okay, I'll try it because my family wants me to try it or whatever. But then I always have the option to opt out.
I like that a lot. Like you can do one dose of chemo, decide that it's not for you, and like not have to get your other doses of chemo. That is, or radiation, whatever it is. I think that is excellent, excellent advice. Um, so I wanted to talk kind of specifically about specific cancers and specific tools or drugs that we're using. So I wanted to talk initially about ICIs. And whether, there was a lot, I think, concern early on that elderly people were, who have what we know to have like immune senescence, were not going to respond as well to ICIs. And I think the data about that is mixed. I was curious kind of what your, operating, thought process is on that.
Yeah, I think the data is mixed. And I think a lot of that, again, has to do with, people being in, on a spectrum of fitness and frailty and, how, physiologically aged they are. Um, I'm not sure I have any data behind that observation, but I think that's a contributor. And I think there's more, data coming out that as far as the side effects of the ICIs, they're not benign treatments either. They have their whole own set of side effects, and I think the big thing to think about with those and is the other coexisting chronic conditions, especially our older adults have a lot, at least two or more, and most of them. So, thinking about how the ICIs might affect their other conditions. Like we see a lot of COPD in our bladder cancer patients, and then, they are a little bit more prone to that, to the pulmonary complications. So I, yeah, I've just seen patients, have issues with them in my practice, and I think there's more data coming out about that.
I think there was this fallacy that I got into as a resident that I have thankfully learned better now, which was, oh, like patients unfit for surgery, they'll just go get chemo. And the truth is that if they're unfit for surgery, they're probably unfit for chemo as well.
That is so true. And yeah, because I think they're both stress tests on the body.
In different ways, but definitely, yes. Those complications after can be devastating after chemotherapy if you don't have a lot of that fitness built up, if you don't have a lot of reserve.
Yeah.
So speaking of ICIs, I know kidney cancer is one of our big, cancers that uses a lot of those. Do you, the pembrolizumab, adjuvant pembrolizumab is an option for patients with high risk disease. Do you approach that a little bit differently in older patients, considering the risks of just having a systemic therapy?
I had a talk with them about some of the different options. Again, I think some of it comes down to, goals and preferences too. For some people, they're really concerned about a cancer recurrence, and so they'd be more likely to, take on an adjuvant treatment or try it out. I think about how the patient is bounced back after surgery too, and, to see if they're really kind of ready to take on another medication, another hit on their body. And then, again, I think we underutilize, you know, kind of stopping and starting treatments with our older adults. So, it's always an option to try something, and if it's not working out for them, to stop it. And just, go on surveillance.
Yeah, yeah. I just want to talk big picture about post-op patients. If they're what when you have a patient who's admitted to the hospital, what tools or what sort of medication adjustments do you make for an elderly patient who's recovering from surgery?
Yeah. So, I think delirium is a big issue for our older adults, especially after, long anesthetic. Um, and so really try to do simple things, right? Like make sure they have their glasses and their hearing aids, so that they can hear and see what's going on. Um, Ideally, it's great to be able to have them in, a room where there's a window so that they can see, when it's daylight, when it's nighttime, and, their circadian rhythms line up. Getting them up and walking, getting physical therapy on board, early and often, I think is really important, and making sure that your nursing staff is clued into that the patient needs to walk, and getting care management involved early, I think is really crucial, just to make sure that any home care needs are met. I pretty much send all my older adults home with home health, just because I think it gives them and usually their older adult spouses some peace of mind. The postoperative period is so overwhelming for patients and families, and I mean that's across the board. That's not just older adults, but communicating with them often, like repeating things throughout the hospitalization, I think is really helpful to reinforce. Making sure they have lots of written instructions, I think is really helpful.
Are there any drugs that you specifically try to avoid or wean quickly in older patients?
Yeah, I really try to avoid opiates, because it's not just the delirium risk, but also like the constipation risk. That's really tough in our older adults. I don't use any anticholinergics. Like if we were thinking about like cancer-urethral resection, um, it's on the Beers criteria. It's associated with constipation, dizziness. I've had patients who have fallen, after even just a couple doses of oxybutynin, um, or have there's also this long-term dementia risk with it.
Right.
So I really try to avoid some of those things. And, like the Benadryl for sleep, it can cause delirium. Really, really avoid that. Any of the like diazepam, Ativan, all of those medications are all on the Beers criteria. Try to avoid as much as possible.
Yeah, I've definitely seen, residents or trainees send patients home with this like cocktail of meds after TURBT. When I was in my chief year, I just started like not sending them with anything. And I would tell them in pre-op when I'd talk to them, be like, you're going to use Tylenol and like, or ibuprofen, and that's going to be fine for you. And, we didn't get, I mean, obviously, this is all anecdotal, like, didn't do a study about this, but, I don't think we had this increase in calls of patients having pain or issues. And it's like, all the cocktail meds that we usually send them with, I think is generally unnecessary for that.
Yeah, I totally agree. I mean, I think I really try to tell my patients Tylenol, if they need something stronger, I worry that maybe there's something going on, so then they should be calling us.
And then are you more hesitant when you're talking, the prostates and kidneys, if they're done robotically, usually go home in 1 to 2 days. Is that something you still try to stick to with older patients, or are you more likely to keep them longer? And then I'd imagine this also gets into that like chronological versus physiological age as well.
Yeah, I hospitalization's really bad for older adults.
Yeah.
So I try to get them home as quickly as possible because I think they're just better off in their home environment. Now, of course, if somebody's uncomfortable, like that to me is a red flag if they don't feel comfortable going home, because I worry about, their social support at home or their resources. I do tend to keep people longer if they're very worried or their family's very worried. But like even for TURBTs, I send them home the same day. I really try not to keep them overnight. Because every day they're in the hospital, they lose functional status. It's this hospitalization syndrome it's a pretty well documented phenomenon. So every day they're in the hospital, they are losing function, and it's not great. It's hard to bounce back from.
Yeah, that feeds perfectly, I think, into a conversation about bladder cancer, which is obviously, I call it the pelvic whipple, because it is like a huge undertaking. Yeah, so the pelvic Whipple, I mean, median age of bladder cancer diagnosis is 73. So we are, well above that cutoff for older patients. So how do you navigate or think about, undertaking radical cystectomy in those patients that's different from younger patients?
Yeah, I mean, I use a geriatric assessment to really try to understand their fitness, try to understand their goals and preferences. And then, we talk about all the prehab things, exercise, nutrition, getting together, their social support, um, and one other tool that we didn't really talk about is the American College of Surgeons NSQIP
Oh,
as
yes.
reader. So if I'm really worried about somebody, sometimes I will put in all their data into the NSQIP risk calculator and then show it to them. And show them, that they're really high risk for complications. So I find that to be a helpful tool as well. And it helps me to kind of think about, should I really be doing surgery or should we maybe tank this person up a little bit? And, in physical therapy, if I can get them ordered physical therapy, I think that's really helpful.
Do you have any strong opinions of robotic versus open approach? I know I'm kind of throwing you to the wolves here since this is usually a very hot topic.
Yeah, I think everything is a tool. And, whatever gets your patient through safely with, excellent oncologic outcomes. I mean, if you're going to undertake this operation in somebody who's older and maybe, pre-frail, you want to really play to your strengths as much as possible. I do think, with the robotic, the blood loss being less, I think is definitely a plus. But if it takes too long when they're under anesthesia for a very long time, I'm not sure that it outweighs the benefit of that.
Right, right. Well, that's exactly kind of what my thoughts are on that as well. And then we already kind of touched on this, the trimodal therapy as an option. A lot of the trials in trimodal therapy were done in patients who just refused cystectomy rather than were unfit for cystectomy. So it's not the best, alternative tool because of frailty being a problem with chemo. But is there ever any specific frailty indication or domain in which you think that it would be better to avoid surgery and do that instead?
Yeah, I'll be honest, I think in somebody who's really frail, who wants treatment, um, I think it's a great option.
Okay, so you do still recommend that over cystectomy?
Yeah,
Okay.
in certain cases. And I always tell them, that, and we see a lot of more advanced bladder cancers, but, for people who especially have more advanced bladder cancers, I tell them that it may not oncologically be as good as, neoadjuvant chemo and cystectomy. But if they really want something, I think it's always an option. And again, I think it's important for them to get all the information, have the conversations with the other specialists, hear what it's all about, and then make a really informed decision. And I think this also comes back to kind of tailoring care for older adults. And I think in talking with some of my medical oncology colleagues, we talk a lot about, what's the patient that should just go straight to cystectomy because they can tolerate only one thing.
Interesting.
If they can't tolerate necessarily both chemo and surgery, but maybe they could get through one of those things. And so, at that point, do you just take them straight to cystectomy and then think about adjuvant treatment afterwards? And if they do okay and if they're, is willing. And I'm not sure that we have great data on that. And I think it's an unexplored area. But I think that also, goes to like the trimodal therapy where, some patients may not be able to tolerate even the chemo as part of trimodal therapy. So for those patients, can you kind of get them through palliative radiation alone?
It's almost like a catch-22 or like an existential question. This patient is going to do bad. Like this patient's going to get knocked out by whatever we do. Like it's going to really affect them. Which one's the better option?
Yeah.
That's tough. That's a tough question to answer.
Yeah.
Um, I wanted to briefly, we're getting kind of close to the end of the hour. We've been chit-chatting for a while. And I didn't want to leave out our big prostate cancer. We've talked a little bit about kidney, we've talked about bladder. Prostate cancer is interesting to me because when you're dealing with like a localized disease, you have two options that are, as far as all the data we have available, equivalent in terms of oncologic outcomes. Obviously, older patients, I think we tend to say surgery is not as good as an option. But, with radiation, especially with higher risk disease, it comes with, usually it comes with a hormone blocker, which can have side effects. So, how do you navigate kind of making that decision or helping patients make that decision? Older patients, specifically, let's say like men in their late 70s.
Yeah. Yeah, it's such a gray zone because I feel like your life expectancy is going up. And if you have somebody who's really fit, in their late 70s, this is again where I think frailty assessment, or like a screener of some sort can be really helpful because, again, I mean, our guidelines are all, age 75, like very clearly chronological age, but, people are getting, living longer. They're living with better health longer. Um, so, what is, at that point, if somebody's in there, over the age of 75, but under 80,
What does that mean?
yeah, does that mean,
Yeah.
could we, actually, they probably would have 10 plus years of life expectancy. So, I think it is a really gray area, and I think we need more data on that particular population. And the ADT risk is real. Actually, I was just doing like my continuing education for my boards, and one of the articles I could choose was on ADT and dementia risk. And yeah, I mean, very
Chose that immediately.
I did. I wanted to see what this, systematic review had to say. And, there is an enhanced dementia risk with ADT. I mean, some of the data is mixed, but, the systematic review, looking at the pool data, I think it is a real concern. But of course, the osteoporosis, the fractures, the falls, also a risk. So, trying to, again, I think that's where frailty assessment can be really helpful. And, the International Society of Geriatric Oncology has some really nice guidelines on prostate cancer in older adults. And they use the Geriatric 8 as their recommended frailty screener to help make those decisions.
So that's a good place to go, a good reference, a good site for reference for that. And then I think, we've already touched on this, but, I've had I've been able to do clinic with a radiation oncologist who was prescribing hormonal therapy. And just like you said earlier, this patient was not doing great on it. And he was like, let's just stop, and there's no reason we have to continue. The problem obviously with something like Leuprolide is they get their dose and it's not, they're skipping their dose 3 months later. So it can be a long time before they start feeling better, but definitely, I think something that he offered, is like, we can always stop.
Yeah, absolutely. That's where the art of medicine comes in.
Yes. Yes. Is there anything else that you wanted to mention or, say specifically to trainees about this area that we haven't talked about yet that you think is important?
Yeah, I wanted to just mention something about ageism. I think that's something that we should all kind of be aware of for ourselves. So ageism is really prevalent in our society. Just having, negative stereotypes towards older adults, or even thinking about the way that we talk about older adults. And it does impact our clinical decision making, whatever our own biases are towards our older adults. And so I would just, encourage trainees to think about, what has been, your experience with older adults, with your grandparents, with other people in your life, and how has that shaped your worldview about decisions with somebody who's older who's sitting in front of you? Um, and how are those discussions happening in your tumor boards? How are people being referred to in your clinical notes? All of our patients read their clinical notes now. So I think it's just something to be really cognizant of. Um, and yeah, just to think about, we're all going to become older adults someday. So
Right.
think about how we would want to be treated and talked to as well.
I'm thinking of a specific example that I did, maybe a month ago. I have this multidisciplinary clinic where we have us and radiation oncology together, and we all see patients, kind of whoever needs us. And I saw this guy came in, new patient, 80 years old, localized prostate cancer, and I was like, oh, I guess he'll be radiation. Before I even saw him. And I walked into this room and this guy looked like he was in his 50s. Like, I swear it was the most fit 80-year-old I've ever seen in my entire life.
Yeah, yeah. That you just never know.
Yeah.
What, somebody brings to the table. And yeah, and the other thing to also think about is that patients direct ageism towards themselves too. And so sometimes, patients may say, "Oh, I'm, 80 years old and I don't need any treatment or whatever." But I think, that's an opportunity to redirect them, and especially somebody who's 80 and fits. I to talk to them about, well, age is just a number. Like, let's see what your physiologic age is, and because we don't want to undertreat the person who could benefit from treatment, and we don't want to overtreat a person who may not benefit from treatment.
I'm thinking about the person that says, if I die, I die. That sort of an example of ageism, or more existential than that?
I think that's a little existential.
Yeah. Okay. All right.
I mean, I think there is some of that. I think there is some ageism in there too, because it's kind of like, oh well, I've lived a long life. Like, I don't have anything more to contribute to society, or and that's a bummer, because
Yeah.
our older adults really do give a lot to our society, and so I think I
The
think
grandmother hypothesis.
yes.
You've heard that, yeah. Well, Dr. Garg, this has been absolutely lovely. I feel like I've learned a lot. What does your typical day look like? What are you looking forward to? We've named a bevy of different, kind of scores, frailty scores that people can harness and use to get a good assessment of patients, including just, a gestalt taking a look at them. And I really appreciate you taking the time to chat with me.
Oh, absolutely. Thank you so much for highlighting this important topic, and really, it's been a pleasure.